Is this one? This one, yes. So good morning, everybody. It's nice to see where the interest of common neurologists is. It's obviously not in myth, but it's more in reality. And stone management, yes, is a very hard reality, and I must congratulate the European School to organize a very successful session. I enjoyed it at least, and I know that the people involved have done a great job. So why would you come and listen to my presentation? Obviously, focal treatment is not maybe the most attractive topic you would like to cover. But in my presentation, I will try to touch a little bit and position focal treatment where I think there is a role. I know that John Varkarakis also had a very nice presentation on that topic. So I was thinking, should I overlap a lot? So yesterday, I changed my presentation slightly. Myth or reality? It's here. Many colleagues are already using focal treatment for treating prostate carcinoma. So it's a reality. But the question is, if a patient comes in your office and is asking for a focal treatment, he already has Googled. He already has seen everything that's out there, that we put out there. And he wants to know, should I have this? Or professor or doctor or whatever, should I have one of the other treatments? Because there are now plenty choices. So in my presentation, I'm going to touch on this. So this was a manuscript that was a real manuscript coming from a doctor who had prostate carcinoma himself. And he asked, so what should be now my treatment? And if you look very carefully, that decision was coming down on 3 parameters. 3 parameters that all of us are using. We check PSA, we've got the Gleason score from the biopsy, and now we use MRI. And based on these 3 ingredients, we give the patient our recommendation. And it's amazing if we talk about personalized care, personalized medicine, that it has come down to these 3 parameters. So the patient sometimes has the feeling that for the next step, he comes in a kind of roller coaster. So what should he choose now? Is it the robotic system? Is it the laparoscopic? Is it the open, the perineal? Or maybe is it active surveillance? Or he says the radiation oncologist is promising him no complications, nothing. Or brachytherapy. He's confused. And I'm confident that many of you are confused as well, because this patient is demanding something maybe that you cannot offer. So looking at these initial treatment options for localized prostate cancer, there is a big variety. Now, what if you are this patient sitting in this office, you just had the outcome of your biopsy, and you feel a little bit concerned? The patient is asking to a person with a vision. So, doctor, what is your vision? And he wants to know about the different options that are available. He's asking you about active surveillance. But what about active surveillance if you look properly at the data? Yes, it prevents overtreatment. It does not modify quality of life. But maybe it also does not offer somebody the necessary treatment that he deserves. Patient's anxiety may be considerable. The uncertainty, the patient is going to demand a treatment. Now, some of us are using risk calculators. And the question is this a risk calculation for the doctor or for the patient, because you want to exclude any risks? So in this active surveillance, yes, it's popular, but maybe it's not the one that you would like to consider. At this meeting, there were a live surgery on robotics. There was a lot of discussions about robotics. And why do we have this interest in robotics? So look at this patient. He says, well, I've read this advertisement, and it says that if I'm not sure, I can even go for a second opinion. But look at this patient. He has a smile on his face. And robotics makes you smile as a patient. Who does tell this, that robotics is maybe the best? Well, it are doctors like this one. Obviously, you recognize this famous American doctor who's on all the billboards, and he says, well, when you come to me, you get the best treatment there is. What about side effects, outcomes? Robotics is the best. Now, this is not the way we Europeans do it. We do it in style. We go to the newspapers. We say, I identified the best surgeons for your prostate. That's how we do it in the United Kingdom. That's reality, gentlemen. We don't talk about myth. Now, keep in mind, we make promises here in the newspapers. But what if you need a second opinion? Can you trust any one of these? No, go to India. That's the best place for your second opinion. So, having said this, reality and myth in whatever treatment we're going to offer, it's challenging, and the patient knows this. I like this slide. I like this slide where we talk about whom can we trust. Well, bring us data. Show us how good you are with a certain approach or treatment. That's what the patient is demanding. Now, what data can we provide? Well, we can show we can cook the prostate in many ways. You can go transperitoneal, extraperitoneal, you can go ascending, descending, and we always claim this is the best. So what about our surgical techniques? What the points of techniques? And you see many videos. You talk about the neurovascular bundle preservation. How can you best do this? Well, most of the time we start cooking the prostate and then we say, I spared the nerves. Well, you spared the nerves of the surgeon, of course, but not always the one of the patient. Apical dissection, yes, tricky, not easy. Bladder neck dissection. We saw yesterday a wonderful live surgery demonstration. I must say, some people look with microscopic eyes and see everything I often have difficulties to see. And what about the UV suturing? Should it be a running suture, yes or not? We had a lot of debates on that. But let's now look at the data when we facing reality. And you ask yourself, what does this have to do with focal treatment? I come to that very soon. Because if you look at the Cochrane Library, this comes from a group from Australia. If you look at this, they looked with the real eyes at what we can achieve with all our laparoscopic open and robotic surgery. At the end, look at what they recommend to the patients. We do not see any big advantage for the patient if we talk about preservation of quality of life for robotic or laparoscopy over open. So if you're a good open surgeon, the reality is you are not worse than anybody else. These are the facts. These are the data. This is different from any myth. But what is not captured in this is something what is even more important. And I like this paper very much. This comes from a very respected site and is already published many years ago, almost 10 years ago. It comes from Memorial Sloan Kettering. And what they did is they looked actually at the quality of their surgeons. This is risky because if the best hospital in the world, let's presume it is in New York and Memorial Sloan Kettering, is willing to investigate for quality their own surgeons, I think then you really are heroes to me in the field of urology, because all of us should be able to do that. Because if you look here at the potency rate, suddenly it's something like 30%. I talk about nerve sparing and all the hocus pocus. Isn't that amazing? We're always talking about 90% in my hands. Well, 90% if I don't do surgery in my hands, for sure. But this is reality. So this is what we get. This is the reality we're talking about. And look about continence rate, PAD-3. You talk about 80%. So what about the other 20% that wet their pants? Jesus, they must be happy. And if you are impotent and incontinent, you got double happiness. I will come back to that when we talk about focal treatment. They looked about the volume of surgeons. So how many patients did they do? And it might even be, as you see here, that those who made smaller volumes had better outcomes than the guys who did a lot of cases. So it doesn't automatically mean if you do only a few cases, let's say 50 per year, that you have poorer outcomes. You might have even better outcomes than the one who does 500 a year, and he says that he is the champion, and he even is going to put this on newspapers or whatever. We also looked at oncological outcomes in this paper. And interestingly, whatever you look at, continence, nerve sparing, whatever, it didn't jeopardize oncological outcomes. So I invite all of you to again read that manuscript. It's one paper. It's one of my favorites. Now, what is the conclusion? You are not surprised. The conclusion says that at the very end of the day, it's the individual surgeon that's maybe even more important than anything else about the outcome in oncological outcomes, but especially in quality of life parameters, incontinence and potence. So when you, tomorrow morning, before you go to breakfast, gentlemen, and you shave yourself, look in the mirror and be honest and ask yourself, where do I fit in here? And I can say, I'm very happy if I fit in the Memorial Sloan catering levels when I do surgery and have 30% and continence in 80%. That's reality. But it sounds a little bit weird because our friends from the radio oncology, they really come with wonderful toys. And at my new department in Istanbul, yes, they've got everything. They've got confocal, stereotactic radiation, brachytherapy, and maybe soon we have proton beam. So can they offer something better than we urologists can? Well, I would say if you have so many toys, there is something wrong. How does it come that you need so many different devices if one is not good? So now let's switch to the talk I was supposed to give, because this is the introduction, this is the reality, and we cannot ignore it. Yes, for focal treatment, there are all kinds of different approaches. You can see we can apply heat, also focal radiation, we can apply cold, electrocurrent, anything, lasers even, to treat focally prostate carcinoma. And we sometimes are a little bit reluctant to listen to this, but this is a little bit strange because if you look here for breast cancer, this is already out for quite some time, and we are actually moving in very late. So how does it come that our friends, the surgeons and radio-oncologists, are they much smarter than us? Or are we just not like to listen to what focal has to offer to us in prostate cancer treatment? And yes, I hear you think, because I can hear thoughts, you think that most probably prostate cancer is different than breast cancer, which is true. Yes, you're all smart colleagues. And yes, of course, not all patients are good candidates for that. Maybe a selected group is good candidates for a focal treatment. And I think that's where the key message is coming from. We shouldn't treat everybody standardized in the same way. So the question is, first of all, what is a focal treatment? So if you look at that, it's a kind of treatment where you destruct the predominant volume of tissue. And we had discussions here the first day. What is then a significant tumor? Can even a Gleason 6 become a significant tumor because it may metastasize and a Gleason 7 not? And I think we are not really sure yet, but we have to work with all this knowledge that we have. The aim is, of course, to reach a good outcome and preserve all kinds of functions. For this, we need to have a standardized approach, but also we need to be sure that we have good follow-up approaches in these. Some communications which are coming out of these are summarized here. And you can see that we have also to discuss if we're going to go for a curative treatment or whether we're going for a conservative treatment where we want to have control over the tumor. Who are the ideal patients? And that's a question that the patient is asking you. Am I the good patient for this? Should I be potent to be a good candidate for focal treatment? Of course not. Does it mean that you need to preserve potency in everybody who is impotent? It's impossible. But continence is another issue. How long should I still be living? Should I be at least for 10 years? Yes, in consensus meetings, we always are very strict. But what about for you the next 5 years? Do you want to live in agony, yes or not? And I think in our discussions that we have in dedicated working groups, I think we try to provide some of these answers. Which setting are we treating, as I mentioned? Is it palliative or is it curative? It all depends on the patient you're treating. And when you look very carefully at active surveillance and a radical treatment, I think that focal treatment is somewhat sandwiched in between. It's not replacing surgery, it's not replacing active surveillance, but it's somewhere in this middle group. So when I go and ask for a new jacket, for sure, they look at my figure and they will not give the one that Professor Konstantinidis is wearing, because my jacket would be a little bit too tight if I would wear his. And vice versa, if he would wear my jacket, it would look a little bit strange on him as well. Actually, he has twice the amount of jacket needed to wear. So in this, the same for prostate cancer treatment and for focal treatment and active surveillance. You need to tailor that treatment. Which lesion should you treat? And we talk always about the index lesion. There is a lot of semantics about it. Maybe it's the largest lesion, maybe the most aggressive lesion. We need to be able to identify that. The other question is, what happens in these cases? That's reality. Prostate cancer is not just this one nice small focus. It is a multifocal disease often. Even within one gland, you can have Gleason 6 and Gleason 7 tumors. Which one to treat? We often don't have the answers to this, so we move to consensus meetings. And in the past years, the past 10 years, we had many of these. And we're bringing with this information of projects we have, tighter and tighter indications. This is coming from registries, but also now from randomized controlled studies. And the number of randomized studies are difficult to run because the patient doesn't want to be randomized against radiation or surgery. They want a focal ablation. You can see that we have been moving from T1 till T3 to T1 till T2 tumors. So actually, we are looking for the cherries out of the pie. How do we identify those? Well, still at the moment, we take transperineal mapping biopsies. Just 16 biopsies is not enough, 12 biopsies is not enough. So you need to properly sample the prostate. And in this, we get a good idea where the tumor is located. What about MRI? The radiologists, yes, they are very positive. They can see all the tumors. But you can, in the literature, see an increasing number of publications coming with the use of MRI, which are a little bit controversial. One sees all the tumors, and some who sees the tumors, they don't appear to be a tumor. So not all lesions that we see are tumors, and not all tumors can be seen. So yes, we need to include MRI, that's my personal opinion, but we should not rely on MRI only. Still, you need to have biopsies. Which tumors are we going to treat? Low to intermediate risk cancers. From consensus meetings, that's where all the experts are, we should say we have been moving away from the low risk, but we moved from the Gleason 6 to high volume Gleason 6. Then we moved from a low Gleason 6 to Gleason 7. So that's a trend. Yesterday there was a surgery of a patient with a Gleason 6 tumor. Question is, does he need surgery? Big question mark. He wants it, for sure. Maybe it was a high volume. Yes, he needs it. So looking at this, you should individualize. But obviously, we do not recommend at the moment to have high-risk patients. You shouldn't do that. No data on that. Which focal treatments are available? And I think also here in Greece, you may have several of them within your access. The academic team has been participating here, the academic team from Sismonoglu has been participating in a study on IRE. John Vakarakis has been co-authoring papers on that. And the interesting thing is from those works, you learn how to position that treatment. But what about cryosurgery? What about HIFU? They're all around. You can also have a focal brachytherapy treatment. So, having said this, it's not a myth, it's here, but again, with a lot of restrictions. Then we talk about the à la carte, because it's always good to look what's on the menu. Can you treat with any source of energy any place in the prostate? So we know by now that for HIFU, it's very good for the posterior, but not for anterior tumors. It's very difficult. Cryo is maybe also difficult, but what about the apex? So it means that you maybe in the future will have dedicated centers, because not everybody should be using it in 1 or 2 patients or having it like shockwave, mobile service. No, maybe 1 or 2 centers in a country where you can go and you are being treated. What about a la carte? What does it mean? It also means that you maybe can have a whole gland treatment, or just a hemigland, or just a lesion that you can identify. And ideally, you should be able to see the lesion, and then you can target it and follow it up again with imaging. So this is again an a la carte approach. What about follow-up? Well, how do you know? PSA is not really reliable. But yes, you can take biopsies. That's good. Patient will not be happy. But you need to be sure that everything that needed to be treated is treated. And the other thing is, of course, contrast-enhanced ultrasound, and you can use MRI. Again, to this, imaging and biopsies are crucial at the moment in follow-up. So, Mr. Chairman, the conclusion is that focal treatment is fast. Yes, you can treat within 1 hour. Focal therapy is effective. I think yes. There are data out there confirming that. It's predictable. Yes, but not in all different modalities equally. It has minimal morbidity. And I hear you think there might be fistula. Yes. But if you carefully, in good hands do it, it has minimal morbidity. And I discuss about this with respect to GU functions. So you want to preserve your erections and you want to preserve your continence. And you have to weigh if your quality of life is in good balance with your oncological outcome. And these data are not mature yet. But the data coming out are coming stronger and stronger. So the ideal scenario means that the patient should not say, I'm going to die in the next 1 or 2 years, but it should also be a relatively good and fit patient. It is good for patients with an intermediate and high volume, low risk cancer. As a workup, you need to have MRI, good quality MRI, and a good uroradiologist in that. And you need biopsies. All focal therapies, energies that are available at the moment can be used, but there are some restrictions. You have to think about a tailored treatment, unifocal or unilateral, because if you treat the whole prostate, you also have a big complication rate. If you talk about follow-up protocols, you come again back to imaging and biopsies. And we still need to talk about failure of treatment, because in the patients there is still a PSA level, because if you don't treat the whole prostate, and you may still have a biopsy positive developing in the oncoming years, does it mean it's a failure? Or is it just the fact that the patient develops a new tumor in the untreated lobe? I was this summer in a very nice place on a holiday, Costa Navarino. I was there 3 weeks. And I said to my wife, what are we going to do next year? She said, next year, we're going to come here 6 weeks. And I said, but we need to do it early. I don't want to look like this. But this is often how our patients perceive themselves. They want to enjoy life in good conditions, and when they go and jump into the sea, they want to enjoy the water from the sea and not the water from within. If you want to know more about focal treatments, I would say join us in Kyoto next year. If it's not for the treatment you want to know more about this, I promise you Kyoto is a wonderful place, and SAU is doing this. Now I hear you thinking, I don't like to travel so far away. I like to stay at home. I must say I agree. That's why next year SAU feels privileged to join you here for our annual meeting in Athens. I want to thank you very much.